Okay, thank you everyone for joining tonight's OTEP clinical case webinar. If you were just here 2 weeks ago, welcome back. We have Dr. Hugh Davie who will be presenting on benzodiazepines in OAT, and we're very lucky to have him here with us. He's head of department at Drug Health Services at Concord and Canterbury Hospital, as well as clinical senior lecturer at the University of Sydney Medical School. And if you could go to the next slide, please. I'd like to begin by acknowledging the traditional custodians of the lands on which we meet and recognize their continuing connection to land, water, and culture. And I'd like to pay my respects to any elders past, present, and emerging. So this is just a map of our registrants for tonight. We have people from all over, no one from far west this time, unfortunately, but we have lots of people and 14 people interstate. So welcome to the webinar. And then as Hugh and I were talking about right before this, it's good to see lots of pharmacists and GPs. I like to see which group has more at each webinar, but also it's really great to see someone from every specialty and role attending tonight. And just a little bit about the OTEP clinical case webinars. These are monthly webinars that we hold. They are recorded and available on YouTube and also on the OTEP website. And for those who are joining live tonight, we will send a certificate of attendance, which we can use for CPD points. And finally, just some housekeeping before I turn it over to Dr. Davie. Please keep yourself on mute. If you have any questions, please feel free to put them in the chat. I'll monitor the chat and read them out as we go along. And please be mindful that the webinars are recorded. Please be considerate and polite, and feel free to participate. We'll have a couple multiple choice questions tonight, so you can participate in the Zoom polls. Thank you. Over to you, Dr. Davie.
Thanks, Jess. So hi, everyone. As Jess said, I'm Hugh. My background is psychiatry and addiction medicine. And I should say I didn't necessarily pick this topic. It's one that was sort of strongly recommended, and it is still a topic that I find extremely challenging to manage. And I don't necessarily have the definitive answers for what to do with benzodiazepines in people with opioid use disorder. So I'm very happy to hear thoughts or challenges or suggestions in the chat, because I don't necessarily have the definitive treatment solution. But in terms of learning objectives for tonight, this is what we're looking at tonight. So understanding the prevalence, how to safely assess benzodiazepine use, harm reduction strategies, some tips if you are going to be prescribing benzodiazepines in this population. So why is there so much encouragement to do a topic like benzodiazepines and opioid use disorder? The first reason is that they are really commonly prescribed. So this is the PBS data from the last 10, 15 years. You can see the actual number of prescriptions for all benzodiazepines, which is the top line, has been decreasing quite substantially over the last 10 or 15 years. I'm sure there are many reasons behind that, including sort of improved education around the risks of dependence, introduction of safe script, that sort of thing. This highlighted one, this blue one that ends with about 8,000 is the number of scripts for diazepam. So in the last year, there were 1.3 million benzodiazepine scripts, only to people who had received a PBS supply of an opioid in the last 30 days. And that went to 325,000 patients. So it's a huge number of scripts where people are combining both benzodiazepines and opioids. That's, of course, for all sorts of reasons, not necessarily in this patient population, but just to identify that it is really common. I thought I would put up the Psychiatrist College indications for benzodiazepines, because it just identifies that it's really quite limited in terms of what they would recommend using them for. And in general, they're quite severe indications. So acute behavioral disturbance and agitation. So for someone who's psychotic, someone who's acutely manic, or they're catatonic, alcohol withdrawal, that sort of thing. And the indications where you would more commonly see them prescribed in the community, such as anxiety and insomnia, they've very clearly listed them as short term. And their final caveat is to make sure that each use should have a defined target and a planned endpoint. And that's often where the scripts go wrong in terms of that sort of iatrogenic development of a benzodiazepine dependence. So again, as part of the college prescribing principles, again, just in the general population, they make a very clear point of making sure you know how it's going to end when you start prescribing. And obviously to be more wary if they do have that background of a substance use history. They do that. The final caveat is for the small subset that may need longer term low dose treatment. So they do leave the door open for people who might need sort of longer than a few weeks, essentially, at a time of benzodiazepines. And they give the example of a severe generalized anxiety disorder without any evidence of somebody whose dose is requiring to be increased over time, which obviously would suggest things like tolerance. And they also emphasize they need informed consent because of the risks in doing something like this. And the only time that they recommend that that would be relevant is if they have tried and not succeeded at all of the other evidence-based treatments for something like a generalized anxiety disorder. So, SSRIs, CBT, that sort of thing. So I put that out there at the start just to show, despite how common these things, despite how commonly they're prescribed, the indications, at least from a psychiatric perspective, beyond the other broader indications for benzodiazepines like back pain, that sort of thing, they're quite narrow. In terms of people who are on opioid agonist treatment, the use is obviously quite high. So this is from just the New South Wales guidelines, but 30 to 60% of people on methadone or buprenorphine report having used any benzos in the last year. And about 10 or 20% of those are high dose, erratic or dependent users. So the ones who are at highest risk, essentially, which is obviously a very large proportion of people on OAT. And that's why it's so highly represented in accidental drug overdoses. So opioids remain the number one cause of drug-induced deaths. And at least broadly across the nation, I know there's a new study that the Pennington Institute has shown that maybe stimulants have just overtaken benzos as the number two cause of drug-induced deaths. But at least from the year prior, benzos remain firmly in the number two spot. And they're usually present in about half of opioid-induced deaths over the years. So you can see this top line in the national data is looking at benzodiazepines as a class. And it looks like it's number one because they've divvied up opioids underneath into more specific ones like heroin, methadone. So when you add up things like heroin, methadone, opioids still come out on top. But it shows you how big of an issue it is. But also positively, it shows you, particularly over the last 5 years, that the benzodiazepine contribution to that, had a big spike, but has now started coming down, hopefully for the same sorts of reasons in terms of that better education and tightening around prescriptions of them. Briefly, in terms of why it's dangerous to combine the two, obviously they both cause sedation in their own rights and have an additive effect as a result. And it's always pretty hard to predict how that will occur. Again, when you add in other things like alcohol, it compounds again on top of all of that. It's particularly hard if someone is using illicit supply of benzodiazepines, as we'll go into. It's very challenging to know what it is that they're actually taking, and if they think that they're having the same dose every time because it says it's a 2 milligram tablet of Xanax, it could be completely different each time, which is one of the reasons that it's just higher risk for developing an accidental overdose. Again, very briefly, I'm sure most people know methadone versus buprenorphine in this context. Methadone is a full mu-opioid agonist with no ceiling on the respiratory depression, whereas buprenorphine does have that ceiling effect. So if you were to add in another sedating agent, you hope that the fact that buprenorphine is less likely to cause that respiratory depression is a lower risk than combining a full opioid agonist with a benzodiazepine. But it's important to note that just because buprenorphine has a ceiling doesn't mean that people are safe to use benzodiazepines on top. It can still cause an overdose, but is probably safer using buprenorphine rather than methadone in that context. However, there's maybe some emerging evidence that the long-acting injection forms of buprenorphine mitigate that benefit to a degree. So we'll see as we've got a bit more evidence under our belts over the next few years if that's the case. Now, in terms of just the general New South Wales guidance, the key factors that they suggest are not to destabilize effective opioid agonist treatment, because obviously we are using that for a reason, to treat something, and a sort of immediate reaction to change that or to stop it or change doses, switch over to buprenorphine, etc., without a broader consideration of the patient is not necessarily the right thing to do. If you do identify benzodiazepine use, it's to be used as a marker of complex needs. So increasing the degree of clinical reviews, reviewing things like takeaway doses, that sort of thing is sort of the first step. Looking for, identifying sort of initial harm reduction strategies is important, talking about not driving while using benzodiazepines, etc. But ultimately starting with just the basic things, giving take-home naloxone, explaining the harms of combining the two, and then going from there. So again, just as a bit of context, what the New South Wales guidelines would say if you're following the algorithm is that if you have somebody who's on an opioid agonist treatment and you identify that they've got benzodiazepine use, suddenly you'd be clicking through all these sorts of things. So it's sort of, they're suggesting specialist level care, specialist dosing clinic for the most part, unless you're cautiously going to be able to use a community pharmacy, monthly clinical reviews, UDSs, no takeaways, etc. So really quite tight restrictions. And obviously this is going to look very different depending on the context where you are working, where in the state you are. But I guess at the very least, it's just to show that it is one of the highest risk things you could be doing in terms of OAT. So we'll launch into case scenario 1, which are just very generic cases, I will say. So I'm very, very happy to have questions or examples thrown through in the chat. So the first case is a 24-year-old female with a background of previous heroin use, but has been stable on methadone for the past 6 months on 2 takeaways per week. As part of her regular reviews, she's had a urine drug screen, which returns a positive benzodiazepine result, despite the fact that she denies any benzodiazepine use. Which brings us to the first question, which is, again, a relatively straightforward question, but how is it best to discuss this discrepancy with her in terms of the positive UDS, but denying benzo use on their history? I'll keep going while I wait for the results to pop up. Hopefully everyone decided that just discussing it with the patient is always the best first step. I guess, the keys being not to use it as something that's punitive, that you immediately start making changes. All sorts of things can, be raised as part of this, particularly things, even things like a false positive result can happen. Often SSRIs can be the trick behind that. So obviously you'd raise it and then want to discuss further, do some more investigations around it. So then in terms of the most appropriate first step in this person, what out of these would you select as the first step? So yes, A is always the first step. So harm reduction is always number 1. Naloxone obviously is not going to do anything for reversal of a benzodiazepine overdose or intoxication, but you can at least get on top of the methadone or other opioid side of things. Or if the benzodiazepines that someone is using happens to actually be something like an opioid or synthetic opioid, nitazene, that sort of thing, it can be helpful in that context. So again, because they're high-risk patients, you just always will have this sort of approach out the gates for everyone who comes in with this sort of context before you make any broader changes with some more thorough investigation. So on review of Miss AB's safe script, we can see one previous script for diazepam from a different GP. It's only been relatively recent. It's only the one script that you can see. And then when this is raised with her, she acknowledges actually using a few from the street as well, timing it around UDSs so it doesn't come back as positive because she's worried about losing her methadone. So in terms of, these are just some generic steps, maintaining that therapeutic alliance always has to be the balance. So if there is something unexpected, like a positive UDS or a GP that's in the mix that you were unaware of, you don't want to immediately come out as punitive or change doses or enforce rules that might make them less likely to continue treatment. That always remains the sort of number one priority to keep them safe. So the immediate harm reduction strategies we've mentioned, integrating benzodiazepine use into the treatment goals when it comes to their opioid use disorder treatment is really important. Ideally, having both of them managed by the same service, by the same person, to keep across all of them, to reduce the risk of splitting, miscommunication, that sort of thing is helpful, because ultimately this is just a really challenging thing to manage. So that does mean if say you are, if you are working somewhere where you wouldn't have the capacity to keep on top of both of these things at the same time, is that the marker to sort of, enlist more specialist support in that context? Identifying.
Hugh, can you hear
Yeah.
me? Sorry to interrupt you. There's just a couple of comments in the chat, and I just thought I'd read them out to you. Dan's saying he's recollecting that there was an OTP prescriber in his area that promoted co-prescribing benzodiazepines, claiming it improved OTP retention. I didn't believe there was any good evidence for this, he says.
I mean,
yeah, so what's your comment on that?
My comment would be maybe if they're prescribing very good benzos. Again, it's all about managing that risk as well. You wouldn't necessarily start somebody on benzodiazepines in order to make sure that they take their methadone. It seems somewhat counterintuitive. But it's not necessarily something that you would flat out reject as well and say, well, never prescribe benzodiazepines. It's all got to be part of that patient-centered context. But I can see the shocked face emojis, which are probably the most appropriate emojis for that comment.
Yeah. And there's also, if stable on OTP and then they turn up benzo use, would you block their driver's license?
I mean, driver's license is a whole can of worms, as everybody knows. Again, when it comes to OAT, the whole point is that if you're on a stable dose, then you are able to drive. Adding in benzodiazepine use, if it's putting somebody, if it's impairing their ability to drive, ultimately still the first port of call is to give them that information, give the person that information that if they continue to use benzodiazepines, they are likely to be impaired, and so that they shouldn't drive while they're using. The onus is ultimately, on the patient to take that information on. As a broader sort of driving thing, if you have ongoing concerns that someone is, say, continuing to drive despite your recommendations not to, and they're putting people at risk, that's when you might consider reporting them without their consent to the licensing authority. Ultimately, anybody who's got a substance use disorder, for the most part, that means they have a condition which might mean they need a conditional license, and that they've got a responsibility to sort of escalate with the driver's license authority to get that all sort of covered separately. So without going into the nitty gritty of driving, essentially, you don't necessarily, if you have a patient who comes to you with a positive UDS for benzodiazepines, it doesn't mean you need to, report them to the RMS. You have a responsibility to inform them of the risks of doing that and inform them not to drive while using them. Inform them of their responsibilities with the RMS, but you're not necessarily, in that context, if you're not concerned about them putting other people at risk on an ongoing basis, responsible for reporting them in that context.
I guess if you had concerns, it's about the level of risk. I mean, your perceived level of risk and how far you would go. I mean, like how far, if they were extremely worrying in their behaviour, you might have to go to the RTA.
Yeah, exactly.
Yeah.
I mean, I can see that Michael McLean is who's on the call, who's sort of the expert when it comes to driving specifically. But in general, if you have concerns that they're putting the public at risk, that's the sort of, I would feel obliged then to report. But the threshold for the most part is that, your responsibility for the most part is to tell them not to drive, and they're putting people at risk. They're adults. They're in, they've got the capacity to make those sorts of decisions. It's on them. And if you have suspicion to believe that they're continuing to drive despite all those risks, they're continuing to use, they're not listening to your advice, that's when the risk obviously is high, and you'd feel obliged to report them under those circumstances. Ultimately, a report is not necessarily going to get them to stop driving. If they're in your clinic and they're completely intoxicated and they've got the keys and they're storming out, I wouldn't be typing something to the RMS, because that's not going to change what's going to happen acutely. That's probably more a call the police, because I'm acutely concerned at that point.
Yeah.
Yeah.
Thank you.
All right. Thanks, Sharon. All right. So, yeah. So, for people who are prescribed benzodiazepines, from other doctors, it usually means that hopefully it means that they've come with an indication for that, like anxiety, like insomnia, something that has made the GP think it's an appropriate thing to do. And oftentimes, the vast majority of times, I'd say that we'd see them in this context, they haven't had the actual evidence-based treatments for those conditions. And so it's important not just to look at benzodiazepines as misuse, but that maybe it is a good door to open a nice discussion point with the patient to talk about treatments for their other, mental health comorbidities and that sort of thing, and get those treated with the proper evidence-based treatments at the same time. It's important to speak with the GP who is prescribing, if you're if they have not been liaising with you back and forth about these things. Obviously, you're needing to consider patient confidentiality and their therapeutic alliance. And so usually I would inform the patient that I am going to speak to the GP about it. I think in the world of SafeScript, any GP who writes a script for benzodiazepines has access to SafeScript, which will show any patient who was on OAT. So you're not breaching confidentiality as far as I would see it. It's all available to any doctor who's prescribing. And so when I get the consent from the patient to do that, it's more that they know that's what I'm going to do. It's not a shock. It just puts everything out in the open, rather than it being something that they feel is happening behind their backs. But obviously it's a very important thing to do, given that ongoing scripts are dangerous. Sometimes it does feel a bit like whack-a-mole, in that patients can find multiple GPs. Once you've called one, they stop doing it, they find another GP. And my approach is just to keep playing that game of whack-a-mole. I think it's happening less and less and less, or at least it feels like it's happening less, that you have these prescriptions coming for patients on OAT, and that's reflected in the number of scripts, I'd say. But just constantly making sure that any doctor who's involved is constantly up to date with what the other one's doing. So again, thinking about increasing the frequency of reviews and urine drug screens, bearing in mind that there are going to be limitations on what you can see on urine drug screens, reviewing takeaways. And of course, if someone's going to continue to use benzodiazepines, do you consider switching them to buprenorphine? Again, bearing in mind if that is actually going to be helpful for their opioid use disorder. And ideally, you have a patient who would like to be safer. And so if they're positively sold on the benefits of switching to buprenorphine in that context, that's the best outcome, rather than sort of needing to feel that you're forcing a patient into something they don't want to do. So in this case, she agreed to all these things, was all very positive. She didn't want to switch to buprenorphine, but stayed on methadone instead. The sort of bedside test for urine drug screen that was sent off for confirmatory testing confirmed there was diazepam in there on mass spec. Initially, our takeaways were cancelled, but after a few negative urine drug screens, they were reinstated. She had that good treatment for her underlying anxiety, but unfortunately, a few months down the track, benzo use came back into the picture. She acknowledged that she was concerned around the risk of overdose and ended up switching over to buprenorphine successfully. So while not necessarily completely eliminating the benzodiazepine use, you've reduced the combined overall risk by doing that. All right, so on to case scenario 2. Again, feel free to throw any questions in the chat about that patient. So on to case 2. So this is a 43-year-old male, lives alone, unemployed, on Centrelink payments, background of an opioid dependence, is stable on relatively large dose of methadone, 170 milligrams a day, and then turns up to your clinic saying he's been using alprazolam daily, 10 tablets per day, but his dealer has just been arrested and he's run out, and he's demanding a script for alprazolam because if he doesn't have any today, he will have a seizure, which he's really worried about. And he apologized for not telling you this earlier. All right. So the first question for this patient is, what is the most likely diazepam equivalent for 10 tablets of alprazolam? So most on D, and then probably the higher ones after that. So the answer is E. So alprazolam is hugely potent when it comes to a diazepam equivalent. It's, again, hard to have a definitive answer. I would probably normally say it's 10-to-1 equivalents, but most guidelines will say somewhere between 10 to 20 milligrams of diazepam is 1 milligram of alprazolam. And most alprazolam that people would buy on the streets are 2 milligram bricks or tablets. So when someone tells you they have multiple tablets of alprazolam, they're usually talking about multiple 2 milligram tablets of it. And even at the lower end of a 10 milligram equivalence, you're talking 200 milligrams at that point. So it's initially very scary because that is obviously a huge dose of diazepam. So when it comes to this patient's progress, review of safe script doesn't show any scripts for benzodiazepines whatsoever. His urine drug screen is positive for methadone, but it's negative for benzodiazepines, and he's not displaying any signs of benzodiazepine intoxication or withdrawal when you review him more thoroughly. So in terms of the next step, which of these would be most appropriate? I think this is an easy one, Jess, so we can probably skip that because I've told you always the answer is A. The initial risk is what needs to be managed first. Particularly in this case where you have somebody who's not clinically displaying any signs that are concerning to make you need to act very quickly. So these other points, obviously to commence 200 milligrams of diazepam when you don't have any clinical signs of benzodiazepine use and no other evidence to suggest that they're on benzodiazepines, obviously is a great way to sort of almost guarantee that you will overdose this patient, which is, again, one of the challenges, is how to identify the veracity of people's use and what dose to put them on if you are going to prescribe. Reducing his methadone obviously is not the immediate step beyond naloxone and everything else. You'd never just withhold someone's methadone unless there's, again, an acute risk of overdose, that sort of thing. And those other steps happen a bit later. So the reason this case has, the reason we've included it is that he's got a negative urine drug screen, despite reporting that he's using a lot of Xanax. And both of those things can be true. So not most Xanax on the streets has very little to no alprazolam in it. Novel benzodiazepines are becoming hugely common in illicit benzodiazepines, particularly the benzodiazepines which you cannot get in Australia. So, odd doses of Valium tablets, for example, like 10 or 20 milligram tablets of Valium, alprazolam, the kind of things that are quite hard to access here, they're far more likely to be illicit, novel benzodiazepines rather than what they say on the tin. They are the equivalent essentially of a synthetic opioid, in that they are usually far more potent, potentially longer acting. There might be a whole combination in there. You're not quite sure what it is. So I've listed a couple that are often found in illicit benzodiazepines, but ultimately what you find is constantly changing. So this is from 2020. So only 8.7% of alprazolam tablets had alprazolam in them. And it's actually much less now. This is getting old. And most of these sort of very strong, weird novel benzos, the one that always trips me up is clonazepam. It's not clonazepam, it's a different one. It's a clonazepam, which is a obviously much stronger novel benzodiazepine or type agent. This is looking over the last 6 years of what actual drug is in the drug you think you're buying when it comes to alprazolam. So 2020, you can see that number on second from the left is that sort of 8.7% alprazolam in your alprazolam. But if you look at the top right, that's what alprazolam percentage is in your alprazolam tablet. So it's mainly at this point bromazolam, all sorts of weird things. So Catherine, I see you've asked, would urine drug screens not detect use of street alprazolam? The short answer is that's correct. So you've totally preempted my next slide, which is that it is very hard to figure these things out. It's just, benzodiazepines in the best case scenario is still a real challenge, an absolute nightmare to manage. Now with all these novel ones, it just makes it infinitely harder again. So what can happen is you can get a false negative on an initial, bedside urine drug screen, like it's happened in this case. And so therefore you don't go digging any deeper to see if there's anything else that might have actually come back positive on mass spec. And similarly, you can have a false positive. So or what you think is a false positive in that a bedside urine drug screen might come back as positive for benzos, but then when you put it into GCMS testing, it comes back as negative because that particular panel wasn't looking for these bizarre novel benzodiazepines. It is a bit of a nightmare overall. So as a very brief summary, the short answer of all of these things is a bedside urine drug screen is only going to be looking at what it's calibrated to look for. So benzodiazepines, yes, no, often misses even obvious ones, like alprazolam, clonazepam, for example, depending on which particular urine drug screen you've purchased. It usually doesn't include these novel benzodiazepines, but again, it's really variable. So at this point, even a negative urine drug screen is not enough to say that they're not on these sorts of other novel benzodiazepines. It's got to be clinical assessment. If you do send off your urine for that proper mass spec confirmatory testing, they're getting much better at identifying these sort of novel agents. Panels are getting bigger and bigger and bigger all the time. Again, the challenge is it depends on which lab is performing it. So the key is if you are constantly sending out urines, particularly for, say, GCMS testing, it's good to keep in contact with that lab with what they test for. And what helps them is an indication from you about what you're looking for as well. So if you have concerns that somebody is using novel benzodiazepines, put that on the form, because then they'll do whatever changes they need to do on the machine to make sure that those are the tests they will be testing. So, even for us in the public health system, these results take a week to come back. It's still only one hospital that does it. You have to specify this is what you're looking for. And hopefully soon we will get a whole bunch of extra results coming out of it. But important to know that even when you send things off for GCMS testing, if you get a negative, it doesn't mean it wasn't there. It might just mean it wasn't tested for. So I've got Dan said a question, who has access to bedside point of care urine drug screen? I'm not sure if that's a question for the audience or that sort of thing. You can just buy individual, dipstick style tests. Obviously in a hospital setting, we've got access to the path labs. But the challenge is broadly that urine drug screens are now really quite challenging to interpret in this context. And so they're really only helpful if there's a clinical indication for them, if it's going to change your management. So that's basically what I've just summarized there. So in this particular patient's case, a repeat urine drug screen a bit later and mass spec proved that it was positive for diazepam. So maybe at that point he had a batch of diazepam in it. Before I go into that, Catherine's written, for your current patient, what's the risk of them not having benzodiazepines if they have been on a high dose of some street versions? Again, excellent question, potentially preempted my slide. So your challenge is if you have a patient who's come to you saying they're on the equivalent of, in this case, 200 to 400 milligrams a day of diazepam, you're not going to be inclined to write them a script for 200 milligrams of diazepam. So again, your initial steps are going to be the same as everyone else going through all those harm reduction steps, informing the patient of the risk, treating them as very high risk, but then you're going to be working clinically on what to do next. So, taking more detailed history than I provided in terms of when he last used, what symptoms he's getting, clinically what you're seeing in front of you, do those things all correlate? And if you have somebody who's not looking like they are at risk of acute withdrawal in front of you, the urgency goes down. Obviously, you're still going to be worried, though. So in this case, one option can be if those doses are whoppingly high and we're really worried because particularly if they've got high risk features of previous severe withdrawal, so, previous withdrawal seizures, delirium, that sort of thing, the safest thing to do is actually to send them to hospital, to at least potentially start a dose reduction at those really high doses. But more often than not, what happens is they go into hospital and turns out their withdrawal is actually not that severe. But when you've got them in hospital, you've got the ability to review them over that 24, 48-hour period to see what their withdrawal actually looks like, see what they're able to tolerate in terms of a diazepam equivalent, and then you can convert that into a community dose. I go into it a bit further, but in general, as a rule of thumb, which maybe not everyone would agree with, I'd usually sit with 40 milligrams a day of diazepam as sort of the maximum that I would otherwise be comfortable to prescribe in the community. Anything higher than that is sort of beyond what the consumer information or the product information says is appropriate. At the very least, 40 milligrams a day is a high dose of benzodiazepine, particularly for somebody on a huge dose of methadone. So that risk is really high in that context. And given that you're not necessarily going to be able to see the patient when he's on them to see if he's sedated, you don't have a lot of evidence to suggest that he's actually had any of these benzodiazepines, particularly without positive urine drug screens. I'm extremely reluctant to start them on a high dose of benzodiazepines in the community, which is where an inpatient brief admission, if you've got the luxury of that, I guess, can come in handy. Otherwise, increasing the frequency of reviews, reviewing them over time, informing them always to go to the emergency department if required, etc., would be the first step. So getting that more information under your belt, seeing clinically what happens. As part of that, managing the risk that you can manage, like reducing that methadone dose, particularly for anyone over 150 milligrams a day. And again, pushing for things like switching to buprenorphine. In this patient's case, he ultimately, was concerned of the risk of overdose and agreed to switch to buprenorphine. A lot of people, when you tell them that the risk of accidental overdose is reduced with continuing benzodiazepine use if they switch to buprenorphine, can often be the trigger that they need to make that switch, particularly for people who have been on methadone for many years at a very high dose. The benzodiazepine side of things can be the precipitant to get them to switch. And, again, as the luxury, some with the luxury of an inner city hospital with an inpatient detox unit, that's something that's relatively easy for us to do. And the process we would normally take is that we would have that person on usually their regular dose of methadone and try and pick a dose of diazepam that we think will hold them with the ability to give more on top if needed based on their withdrawal symptoms. So for somebody like this, again, usually we would probably start them on something like 10 milligrams QID of diazepam with some PRNs on top and withhold any of those doses if he's looking drowsy. And I guess anecdotally, what I have found over the years is that people who report street benzodiazepine use, their withdrawal tends to be not as severe as you would expect, given the doses that they are saying. So somebody who might be on a 200, 400 milligram a day dose equivalent based on what they're reporting might actually be oversedated at 30, 40 milligrams a day. And you just don't know that until you can see it and treat it. I find anybody who's on prescribed benzodiazepines where you can see their documented use every single day, they've never missed a day, that sort of thing, even if the dose is only 10% as high, those withdrawals tend to be much harder to manage. But again, there's ultimately just no way of knowing until you can see it for yourself for the most part, which is the real challenge. So again, managing those other things is usually the best approach, managing other ways to try and get them to stop using these other benzodiazepines rather than just writing them an equivalent script. So we'll then move on to case 3, which is a local prescriber is retired, transferring all of his long-term OAT patients, and you're lucky enough to inherit a 50-year-old male who's on a stable dose of Buvidal, has a background of anxiety and insomnia, which has been managed by the same GP over the many years. And it's managed on, among other medications, 12 milligrams a day of alprazolam, 40 milligrams a day of diazepam, and 30 milligrams a day of temazepam. And you can see throughout the letter that those doses have been slowly escalating over the last 10 years. But when you look through SafeScript, you take the patient's history, there's no evidence of them using street benzodiazepines. There's no evidence of losing scripts. There's no evidence of them getting scripts early. It's all been as prescribed, single prescriber, nothing dodgy, essentially. Which brings us on to our next question.
Okay, we have 95% who have chosen C.
Very good. Nice straightforward one. And then I think this might be the last question. While we're doing that, Jess, I can just see in the comments a question about other jurisdictions, essentially saying all of this challenge with novel benzodiazepines and urine drug screening is just not sustainable, in short. And so do you see a role where we as clinicians in GP land use more empiric medicine than very expensive and cumbersome UDSs such as mass spec to diagnose the patient and help them out of their dilemma? I mean, the short answer to that is yes, in that urine drug screens are now just a huge challenge. I wouldn't necessarily throw the baby out with the bathwater in terms of how to use them. The important part is to know where their limitations are and using it as part of your broader clinical assessment and treatment, but not to just use them as the definitive answer as an automatic test that you do all of the time. So the using empiric evidence is, part of your overall treatment. But I guess the key is that when you do use empiric medicine, which I'm assuming in short, you mean benzodiazepines or diazepam as a script in that case, that it's done safely, given that we just have quite limited information at this point in terms of what a patient is able to tolerate. So bearing all those things in mind, the short answer to your question is yes. But how you do that, in which context you're in, is going to be variable. And that's why I tried to hose down everyone's hopes that I would somehow have the trick or solution for this, because I don't, beyond, again, reducing all those other risks, being super cautious, a lot of supervision, seeing what they can tolerate, clinically what you're seeing in front of you, ideally the luxury of an inpatient admission to really review it properly. But bearing in mind, saying that from the luxury of a big inner city hospital. So in terms of this one, I think everybody ticked B as well. So I think everybody's got it, in short, and yet everyone is still a bit worried about how to do this, because I'm still worried too. So in terms of if we are going to go down the route of prescribing benzodiazepines for somebody with a benzodiazepine dependence, the first step is to actually, identify that somebody wants to come off benzodiazepines or stop using them. There's no point writing somebody a script if they're going to keep getting them off the streets, or if somebody who's prescribed benzodiazepines is just going to keep getting those prescriptions from whoever was giving them to them. You want them to want to stop, or reduce those risks at least. Often you will find that they haven't been told the positives of reducing, in terms of clearing foggy mind, reducing those risks of overdose, like they can see real benefits of stopping. Usually they are just sort of so worried about losing their script that they become so defensive that it's quite hard to have a discussion. So opening it up in terms of the benefits of reducing can be helpful. So I don't know why I went back there. And ultimately emphasizing that what you're discussing with them when it comes to, say, in this patient's case, who is on multiple sort of iatrogenic benzodiazepines, is that we are still going to be treating whatever the underlying indication was in the first place to be on them. It is hard for people who've been on benzodiazepines for years to consider coming off them, because whenever they've missed a dose, or they've been late in their dose, their anxiety's gone through the roof, they can't sleep. And that just only reinforces the fact that they must be on those medications to manage their underlying, indication to be on them. So a good amount of time spent on education around, withdrawal symptoms, that over time they won't need to be reliant on them to manage those symptoms, that there are better treatments out there that don't have those same side effects, goes a long way. And you'd be surprised at how few people are aware of particularly the withdrawal contributing to their symptoms as opposed to helping them. So in terms of the specifics on how to do it, this is where it gets a bit sketchy in terms of figuring out who says how to do what. So the first one I've got in here is the therapeutic advisory group. And when you look through it, when they mention reduced dose by 25 to 50% each week to month, you realize that they're talking about, say, patients with no history of a substance use disorder, usually patients over the age of 65. And this is about how to manage people who've been inappropriately started on them for, say, insomnia over a long period of time. So very different context to the people we would normally see. So maybe not necessarily the most useful structure to use. I've got the College of GPs recommendations. And again, they recommend taper lengths based on how long someone has been on them. Again, it's on the faster side, I would say, and that's again probably a reflection of the fact that they're talking about the broader population who are on benzodiazepines, not people who have necessarily a benzodiazepine use disorder or who have that extra risk that comes with being on OAT. So I've got the next few slides based on the American Society of Addiction Medicine, so apologies. But it is helpful because it does give some more specifics. And at the very least, it just seemed to align with how, we've previously been managing it in the community. So it initially, identifies who's best to be done as an outpatient versus an inpatient. And again, the vast majority is as an outpatient. There are those risks that we mentioned earlier where you just are really worried about an acute overdose, acute severe withdrawal, that probably need at least to start as an inpatient. These are all very generic tips. They're not ones you must do, as we'll discuss. So firstly, trying to consolidate to a single agent. So if people are on multiple benzodiazepines like this patient, or they report using multiple benzodiazepines illicitly, trying to find what that equivalent dose is of diazepam usually is a nice long-acting one, sort of the methadone equivalent, I guess, of benzodiazepines is usually the first step. But again, it's going to be patient specific. If you have somebody who's just refusing to switch from their oxazepam or their clonazepam, and they'll agree to reduce that, but refuse to switch over to diazepam, it's probably worth just going with the patient on that and say reducing their clonazepam instead. Ideally, keeping it to one clinician across all these things to reduce splitting can be helpful or is helpful. Longer acting benzodiazepines, so diazepam, as we mentioned, agreeing the goal before you start. Does this person want to actually come off them altogether? Do they want to reduce to the point where maybe their overdose risk is substantially lower? And again, as I mentioned earlier, just as at least my rule of thumb, 40 milligrams tends to be that line in the sand where I'd get concerned if they're higher than that. And maybe I would do a faster wean in hospital first to make sure they're safe before then continuing their wean as an outpatient at 40 milligrams. Now, I told Jess I wouldn't run over time, so I'm going to go very quickly now. So in terms of the speed of the taper, it's slow, in short. So 5 to 10% every 2 to 4 weeks is going to take you months to come off a big dose. And I guess the key is also that this is looking at a percentage dose increase, not a fixed dose decrease. So if you have somebody on 50 milligrams a day, and you pick a dose of, say, 5 milligram dose reduction each week, every week until you get to 0, what ultimately happens is that first dose reduction from 50 to 45 is a 10% dose reduction. So the patient probably doesn't feel it that much. But when you get down to the bottom and you're going from 15 to 10 milligrams, that's suddenly a 33% reduction. So their actual percentage in terms of the withdrawal symptoms they feel gets larger over time. And so picking a fixed percentage reduction should ultimately reduce the symptoms. Again, it's hard to come up with a plan for someone who's not motivated. So building that motivation first is important. So in this patient's case, he, despite all the risks being told to him, he declined a transfer to diazepam, declined going into hospital, but was agreeable to start reducing because he could see the benefits. So in this case, we started reducing the alprazolam, which again, involves authority and all sorts of things. It's all very controlled dispensing amounts. So, in this case, you might think of weekly dispensing so that they don't use it up too quickly, regular and drug screens. This is sort of an amalgamation of multiple people, but often what happens in this person's case, it's stalled at multiple times. Their withdrawal symptoms got too much. They got too worried about going down. But we paused at that point. Withdrawal symptoms sort of stabilized, motivation picked up again. So that the key is to keep that momentum going. You're allowed to pause, but ultimately that you don't leave it there. You just keep that momentum up to keep pushing to take a little bit more. And even if it's just a tiny little bit more at a very long period of time, that can be positive progress. So eventually you can get it low enough to maybe consider switching to diazepam if they're happy. These sorts of patients who take, who are on huge doses to start, usually take years to get them even to that nice low dose where you might even consider keeping them on it, because the challenge of getting them to 0 is probably not outweighing the benefits of them just remaining in treatment. So it is, in short, a challenge that takes ages, and you need the resources to do it. So again, if you're, don't have the luxury of us in a big OTP, that does become challenging. And it is that sort of point where you do consider sort of, referring out, getting specialists involved, that sort of thing. So I've got a few more questions in there. I'm in final thought and resources. So I'll answer some questions now. So Catherine's asked, what about the elderly female patients who are on long-term benzos and then prescribed opioid pain medications? Great question. Happens very often. You hope that that's not an addiction medicine issue, but more a GP issue. I think that's where things like Safe Script are very helpful because they get flagged and that sort of thing. So yes, it is obviously dangerous to do so, and that is where you consider altering one or the other. So I've got a few compliments for being confident enough to use the US stuff, which is good. Alison says, how often do you ask them to pick up? Again, it's going to be patient specific. So if they've got mobility issues, maybe they go a bit longer. If you know they've got people at home to monitor it, maybe you can stretch a bit longer. If they've demonstrated that they're not running out of scripts early, that sort of thing, you can stretch it out longer. If they are somebody who every single script they've ever had is used up within the first 2 days and it's supposed to last them a month, that's obviously giving you an indication of how frequently you need to get them to pick up. So I think one of the big challenges with benzodiazepines in the community is, in general, the smallest script you would see for the general population is a box of 50 tablets of diazepam, which is a huge amount of tablets. And there's nothing to say that you need to do that. So when you see that the indications for benzodiazepines from the College of Psychiatrists is short-term, 50 milligrams doesn't feel that short. So you can be specific on your script about how many tablets to dispense or how frequently to pick up. So it's going to always be patient specific, in short. So here are the key takeaways, essentially, in that benzodiazepine use is common. It's not caused to destabilize somebody's opioid agonist treatment out the gates. You still want to make sure that they're retained in treatment, because that is ultimately going to be the most beneficial thing for them. You hear anyone saying they're taking alprazolam, it's not alprazolam. Urine drug screens are becoming increasingly challenging to interpret. If you are going to prescribe benzodiazepines, it is challenging. You're not going to be able to guarantee that they're not taking illicit benzos on top, particularly if a urine drug screen is just going to come back as positive regardless. So you're going to need to have very close monitoring, stage supply, checking safe script, clinically just ensuring that's all correlating with what the history is. And ultimately ensuring that whatever treatment that they want benzodiazepines for is being treated in the best possible way. And that's usually the part that's the most neglected, to be honest. So combining those all together.